THC metabolism and how your metabolism could influence cannabis use disorder risks, or just if you like it or not. So my story comes out of Neuroscience News, and researchers have linked differences in THC metabolism to varying effects of cannabis use and the risk of developing cannabis use disorder, which I'll call CUD. The study, which included young adults, both with and without CUD, found that genetic differences in the THC metabolizing enzymes can lead to stronger and longer lasting effects of cannabis, especially among females who metabolize THC more slowly. Now, this connection between THC metabolism and CUD risk, particularly observed in a younger demographic, underscores the importance of understanding individual physiological responses to cannabis. The findings also suggest potential for targeted interventions and the need for educational programs to inform teens and young adults about their unique risks regarding cannabis use. So there's a few key facts that came out of the findings. First, sex-specific effects. Females with slower THC metabolism are at a higher risk for CUD, while males with similar genetic variations report more negative initial effects of cannabis use. There are genetic influences. About 25% of people have a genetic variant that results in slower THC metabolism. This impacts the intensity and duration of cannabis effects. And third, the educational importance. The study highlights the need for educational programs that address individual differences in cannabis experience and the risks of CUD, particularly among adolescents. Now, I've had a lot of folks come through Oaksterdam and say, you know, I'm doing this for somebody that I love, not for myself. I don't actually like the way cannabis makes me feel. I say, well, we're not going to push it on you. You don't have to consume it yourself in order to understand it. The other question that I would always ask them is, hey, was that first time you tried cannabis when you were drinking? Because oftentimes it's when you're drinking that you've, lowered your resistance, you're willing to try new things. But oftentimes that combination of alcohol and cannabis results in deleterious effects, vomiting, dizziness, paranoia. Just that did not make me feel good. No, thank you. And maybe try it again without the alcohol and also the method of ingestion and the type. So this just is fascinating for me personally that, and of course, it's genetic. It's based on metabolism. So these findings were recently published in Addictive Behaviors by the Medical University of South Carolina researcher Rachel Tomko. She's a PhD, and former psychology intern Crystal Davis, PhD. They're both postdoctoral fellows at the University of Pennsylvania. I would encourage folks to read this because CUD is currently affecting approximately 1 in 5 people who use cannabis. So we're talking about 20% of the population that this leads to problems. Now, this is where I get a little curious because they call it withdrawal symptoms and cravings when not using cannabis, difficulty reducing cannabis use, and a need to consume more of the drug to experience the same effects. Do you mean homeostasis? Is this just feeling good because you're healthy and you're not experiencing a deficiency in cannabis or cannabinoids because your body endogenously is producing enough and they are combining properly with your receptors? This is where I start to question the science. We are just beginning to understand, the study goes on to say, some of the effects of how people metabolize and process cannabis. For this study, the researchers recruited 38 young adults, 18 to 25, that said they do have or have been diagnosed with CUD, and 16 with a non-CUD substance use disorder, meaning I'm addicted to something, but it's not cannabis people. The age group was chosen as they are 3 times more likely in this age group to have CUD than either teens or adults over 26 who use cannabis. This age group was important to study because the brain is still developing and blood samples were collected from the study participants. So I just want to note again, normal people who regularly consume cannabis were not part of this study. Only people that had some type of use dependency disorder, and they compared cannabis use disorder to some other dependence disorder. I think what we can take away from this study is the differences in sex that are evident in the data that this definitely affects more women than men, that they realized very quickly there were sex-specific effects going on that cannot be ignored. And so if nothing else, to understand that young females may metabolize cannabis more slowly, maybe at a higher risk, and why, I think this, I'm hoping that this will really encourage more studies along these lines, and with a much larger base of individuals. Unfortunately, we often only study individuals that present with a problem, and then, blanket that out, extrapolate that out for all of society. They never compare the folks that are just fine, and what those ramifications were for them. So as we close out Women's Month, I just want to encourage everyone out there, please support those business people of the female persuasion by putting your purchasing dollars where your heart is, and give support, not just lip service. I am Dale Sky Jones, coming at you straight out of Oaksterdam.
This is some real interesting stuff.
Yeah.
So when you were talking about the subjects that they recruited, they had to have been diagnosed with cannabis use disorder, right? Is that what you said?
That is how I read it, is they had been diagnosed with either CUD or another disorder. Yep.
So let's ask Dr. Talleyrand. So Dr. Talleyrand, assessing cannabis use disorder in patients, what does that mean? So these patients that were enrolled here all had a doctor said, yeah, you smoke too much weed, right? Is that what it is?
Yeah. It's a sham diagnosis, which makes this study problematic. Bad data in is bad data out. Cannabis use disorder is a sham diagnosis. It really, even in studies, they can just say, you're using cannabis, you have cannabis use disorder, even though there's no problem. And the idea is to identify the problem, not the fact that you're using cannabis and gaining normal tolerance, normal withdrawal symptoms without a problem.
Mm-hmm.
So maybe they did study normal people without a problem and compare them. After all, it's the people that got caught, right? And this, I will underline what you just said, Dr. Talleyrand, because, for instance, in Florida, part of the scam, the current senator, former governor, his family and his wife's family between them own more than half of the drug testing facilities and the drug treatment facilities. And so you get busted, you're not a medical patient, you're required now to go to a treatment facility, your head takes that bed instead of somebody with opiate use disorder or somebody that really truly needs this help, and then the state just pays the facility for all their time and trouble of treating this horrible disease of cannabis use disorder.
And those guys are cashing in on that.
And keeping it illegal for adults in the process.
Right.
Mm-hmm. And pushing back. They're pushing back. This is their way to find cannabis problematic. It's historically, cannabis has not been problematic. The only thing that's been problematic are those who are governing other people and want to find problems with cannabis users, because cannabis users tend not to listen. They tend to be rebellious. They tend to be introspective. They're just not going to join the crowd. And so this is not good when you want to get everyone to fight a war or what have you. Listen to your doctor.
There's one other issue, if you follow the money, Dr. T, that cannabis consumers and businesses tend to do well and have nice things like cash and property. And when you look at like a meth dealer, they actually have to pay to raise the property. They have to go tear down the property and dispose of everything, where in cannabis, they can take the money and it's often split between local and federal law enforcement. This is why property forfeiture is a thing. And this is also why we are keeping it clearly illegal, because property forfeiture is how many of the enforcement agencies pay for their nice things.
Mm-hmm. Very, very true. Very, very, very
Hey, Dr.
true.
T, if bad data is bada, does that make bad data beta?
Okay.
That's a pun. I'm not going to answer that.
But let me just say, earlier, y'all were talking about meso, and of course I Googled it. It's the setting between macro and micro from ancient Greek, mesos meaning middle. You're welcome.
Ooh.
Thank you.
So
We're next gonna have a quantum licenses.
I have a serious question for you guys. Serious question. So we all know that hemp and cannabis are the same thing, right? It's all the same. It's all the same plant. So my question is, does cannabis hypermesis syndrome also affect people that would consume hemp-derived products?
Probably not. What you're saying is Delta 8 products where they are.
I'm just.
You can't.
Well, this is kind of more where I'm really really.
Can people with CHS use hemp products? Is that what you're saying?
Yeah. Yeah. Exactly.
Yeah. Because
what I'm imagining is this ultimate scenario out in the great state of Milwaukee, you guys, that since a side effect of CHS is puking, vomiting, throwing up, I can just imagine all these people going into the bar for the first time, trying to go and have a cannabis beverage, and then finding out that they have CHS and they just start puking. But they're not going to be able to figure out if they're drunk or high.
Realistically, though, cannabis use disorder, we're seeing in young males who are dabbing all day, and then they're like, "Oh, I'm nauseous, so I should use cannabis because cannabis helps nausea," and then they start vomiting. The cure for cannabis hyperemesis disorder is stop consuming cannabis for less than a week, and your body will reset, and stop smoking. So you're wasting it.
Does that work for everyone? That doesn't work for everyone, though.
Yes. Really, so the fundamental essence of your question is: does the dose of THC, is that responsible for CHS? Right? Because in hemp-derived products, things are going to be much lower in dose. Mm-hmm. And I would defer to Dr. T, but I would tend to think that lower dose of THC is not likely to induce an episode for cannabis hyperemesis syndrome. But I don't have any clinical experience or data to draw that on, but perhaps Dr. T, is it directly correlated to dose of THC?
No, it's associated. So first of all, whenever there's a syndrome at the end of a diagnosis, it's a collection of symptoms. We don't really know why they're all connected. CHS tends to be from people who use high doses. They wouldn't throw up at the bar. They usually throw up the next morning. So almost like a withdrawal effect from cannabis.
Interesting.
Often they go and use THC to stop the vomiting, which it does. As some people have tried to use CBD along with THC, but anecdotally, I haven't heard that has worked. It's a molecularly interesting idea, but I haven't seen it happen in the real world so much.
Well, what we do know from clinical work that Professor Meshulam and others had carried out is that THC at very low dose, psychoactive dose, completely blocks all chemotherapy-induced nausea in cancer patients. Completely blocks it. And Dr. T, I think you'll agree with me, there's many things in the body and many things in biology that have what are called a biphasic response. And it really depends on the dose of the medicine, a dose of the active ingredient, on whether or not you're going to get controlling of nausea, or could it actually do just the opposite at a much higher dose because you completely overwhelm the receptors or the body's ability to deal with such a high concentration at such a high dose. So certain things, again, at a much lower dose, not going to see cannabis hyperemesis. So what I would, again, hypothesize based on that, Jason, to answer your question, is that low dose beverages, you probably won't see a cannabis hyperemesis type episode happening. But again, that's just a hypothesis. But I would, again, go back to the literature and see if they've actually looked at THC dose being primarily the thing that's, going to switch that biphasic response from something that would control nausea at very lower dose to something that would actually induce it.
Interesting. Very, very.
Testimonial here.
Man.
I have cyclic vomiting syndrome. Cannabis helps me most of the time until it doesn't. And there are more than once where I go take a higher dose, and that is what triggers uncontrollable vomiting. If I go take a dab, I can't stop throwing up after that dab. But if I just smoke a joint, it helps my nausea. So finding that balance, I don't believe that I have cannabis hyperemesis. I have cyclic vomiting syndrome, a collection of symptoms where I get triggered and then can't stop throwing up. So it's fascinating to me to hear about this, and anyone looking to do clinical research, I'm right here.
So you're not a CHS
Do you go to
denier.
CVS? Do you go to CVS to treat your CVS?
CVS does not have medicine that helps my CVS. I can't keep water down. I throw it back up again.
So you're not a CHS.
I can't vomit smoke though, and that's why vaporizing is a treatment for me.
Interesting.